Good afternoon, everyone. Can you all hear me? My name is Shannon Kupka. Welcome to our half-hour hot topics today, which will be on de-escalation strategies. We're very excited to have this particular topic today. We are going to be talking about de-escalation strategies, and we have with us today our Bureau Chief from the Programs Operation Bureau of the New Mexico Department of Health. This is Christopher Burmeister. Without further ado, I'm going to turn over the event over to Chris.
My background, I've been dealing with direct care staff and training direct care staff for over 20 years of direct care staff within a psychiatric setting. So folks that provided care, support, services to adults, adolescents, and children, primarily in secure units and outpatient programs. So in 20 years, I've seen a lot of staff, seen a lot of behavior, and dealt with a lot of crisis behavior, both with staff and with individuals that were trying to provide care. So we'll talk a little bit about those situations, and hopefully we'll give some tips, but hopefully most importantly, we'll whet your appetite. You'll want more, and we'll talk about some resources and some funding to allow you to explore this more, and maybe even go and get some certification in your facilities for your direct care staff to help improve how we interact with residents and where they live. There will be a chat at the end of this. They will cue you guys to participate. There are, it looks like, multiple things like verbal aggression, physical altercations. Advance the slides. Resident-to-resident aggression, resident-to-staff aggression, all of the above. So pick which topics you want to kind of focus on at the end of this, and we can address any specific areas you want to talk about. What can facilities do? Well, there's multiple things that we can do, and we're going to talk about those today. The first thing that facilities should have in place are obviously policies and procedures and how we deal with the population. And this should go in all levels of kind of care that we're providing. So not only the medical care, what medications we're giving, what treatments we're giving, but also what behavior do we need to address, positive or negative, what works and what does not work. All these things should be included in how we assess residents as they come in our facilities, how they evolve over time, how they change over time, and how the facility adapts to provide supportive care to the individuals that they're servicing. Risk assessments and monitoring are obviously a key characteristic to this. And these things are only as good as the people doing the assessments and accurately reporting what individuals are doing or not doing. And this is a really important part. The assessment leads to obviously monitoring, looking at over time what occurs, what worked, what didn't work, what can we rule out, what can we bring in that's innovation to deal with people when they are in crisis. We don't want the repeated same behavior, so we should always be trying and looking at different things that might work or different people that have ways of dealing with this kind of behavior. How does the environment of care, another crucial part. When we think of nursing homes, the challenge is these are people's homes, and they don't always look like the homes that they came from. The rooms might be similar, they might adorn them the same way, bring in their own family things, but no matter how you count it, it is not the home they came from most likely. So that alone creates potential problems. You're in an institution, you've got different people providing care, you've got people coming and going, you've got visiting hours, you've got noises, you've got so many different elements in there that are different that can be potential triggers to individuals in your care. Care practices. What do we do to deal with and to put systems in place is another important part. What's your staffing, and how does your staff impact crisis? Is it a team that understands their role in crisis? And we'll talk a little bit about that and how our behavior affects the environment of care and the people around us. Not only the people we work, but obviously the residents that we serve. And training, the important part of not only upfront training when you start so that you understand some of these behaviors, and it can be a complete range of behaviors that we're dealing with. Some related to some of the disorders they have, some related to just who they are and where they came from, their temperament and their personality. And then another important part of training is how do we provide continuing education on the stuff that people do well And how do we provide education and support for when we have issues or things that don't go as well? And all those are very important parts in having a successful crisis protocol and program in your facility. The pre-crisis initiatives and things that you should think about. When do incidents occur? When do trends occur? When do things happen? Where's the potential risk? Where's the high risk areas? Where do we see this? Some of the common things when we start thinking about residents, and we really have to kind of look at each resident individually. What is going on and what does their behavior tell us about what they're asking? Residents with dementia or all different kinds of issues in these facilities aren't going to be the best communicators. You're not going to have an individual in most cases come up to you and say, listen, I used to wake up at 9 o'clock in the morning, don't come in my room until 9 o'clock. I really want to be left alone in that time, and when you do come in, I'd really like to have my cup of coffee, and I need some time to wake up in the morning. I'm a night person, and if you do that, I'm going to have a much better day. What you'll usually find is you'll start the morning off, you'll wake them up, and there'll be some sort of acting out as a result of trying to adapt to the schedule of the facility instead of a schedule that fits their routine. Changes in residents. Another important characteristic of when we look, people aren't static. They're not always the same. There can be changes as a result over time. Obviously, as we age, hearing, eyesight, confusion, a whole cross-section of things that occur that we really need to kind of focus on. And sometimes we get kind of lost and forget, well, Miss Jones has always been like this. Well, that doesn't mean on Tuesday that something doesn't change with Miss Jones. And there can be a lot of things that contribute to that. Times of day. This is where we start looking at trending too, and we'll talk a little bit about who does the trending of acting out or problematic behavior in the facility. It always surprises me when I hear some staff, well, you know, Miss Johnson just flipped out on me during its shower time. And we start doing an analysis and we start finding that Miss Johnson has had a lot of problems at shower time. It hasn't been a good transition for her. It's been very problematic. And then we start drilling down, well, it's not at every shower time. It's maybe when Cindy showers her. Maybe she has an issue with Cindy. Maybe there could be a million contributing factors, but it's important that we analyze and drill down and find out exactly what the trend is. And that's a very important thing when we look at that individual problem and individual focused care areas. During transitions, changes in activities. Believe me, we do licensing and certification, and the licensing and certification part, specifically around surveying, we are acutely aware that things change when you have 4 visitors coming in and looking at care. They change in residents' behavior, and they certainly change in staff behavior. And we're very acutely aware of that, and that's always been a worry when we walk into a facility. You should also be looking at those things. What is consistent in your facility? What changes? How can you create consistency? We know as a fact that people do not like change. Elderly people in particular, they like certain things to happen, certain ways to do it. And this is their home, and those things really should try to be accommodated. But be aware of those kinds of activities and your participation in those things. Unfamiliar staff, low numbers of staff. We always worry about weekends when we're in survey. Are they getting their needs met the same way that they are with other staff during the week? So staffing can be a crucial element of getting people's needs met. Timeliness. A lot of complaints come in where residents feel like they're not getting their needs met. And your version of getting their needs met and their version of getting their needs met might be very different. And it's very important that you come to an understanding of what that is, or you're setting yourself up for crisis, you're setting yourself up for complaints, you're setting yourself up for unsatisfied staff. So as important as this is for residents and residents' care, we also have to look at how a lot of this communication helps support our staff. Frequently, we will hear staff say, you know, Mrs. Jones is very difficult. Well, has that been translated to your director of nursing, or your supportive staff to assist you in this? And we'll talk about post-crisis debriefings and the importance of that. Another big element of a good, well-trained crisis program is supporting staff. People are more apt to stay in the position if they have support from their direct supervisor understanding and continuing education to help them be successful in the job. Environmental stressors, we've gone through what's present in that, unusual visits, bad news, and think how common this is not only with residents, but also within ourselves. You're going to work, you get some bad news, you go into the facility, and you're in a bad mood because you've gotten bad news at home, and now you're supposed to provide pleasant care to these residents. How can your behavior and what's going on with you affect the environment and affect residents and how they function within their home? Tracking patterns and being proactive. You're only as good as the analysis you do and how you look at things. One of the things facilities should do is they shouldn't not expect crisis happening. They should expect it. You should always know that crisis is a normal part of human development. People will be in crisis at some point. All of us are. It's a matter of what kind of support, what kind of training, what we do in order to kind of plan in advance for this kind of behavior. During the escalation, how do we contribute to that? Some very important parts of this is when we're talking about during escalation is our role in this. All behavior has meaning. Usually it's some sort of unthought of or inability to communicate a need of some kind. Well, they're trying to do that. We're not able to figure that out all the time. And then we have to look at ourselves of how do we contribute to either de-escalating, calming the situation, or escalating it. And we can do a lot by ourselves. Paying attention to ourselves is one of the most crucial roles when we deal with crisis. Our body language, our facial expression, all those are crucial. They say that over 80% of what is translated when somebody is in crisis, that highest level of escalation, is body language, your space, how you walk, how you position yourself, your voice, your cadence and rate in your speech. If you put all these together, and it's a very simple thing to kind of think of, is when you run to a crisis situation and Mrs. Jones is screaming, yelling, the most common thing is we start to yell over them, or we invade their space, or we do all combinations of things. Our body language is imposing. We're standing over somebody in a wheelchair. If you ever want to feel something really unusual is sit down in a chair and have a very tall person stand close to you and over you. It's difficult. I'm a 6'4" person. And when I've done it and I have somebody standing over me, I'm used to being taller than people. It feels very intimidating. It makes me feel very uncomfortable. And frequently we'll see staff to where they'll be even communicating the right thing. Mrs. Jones, calm down. It's okay. We're here to take care of you. But their body language says something completely different. It's aggressive or it's not supportive. And there are many training programs that tell you how distance affects you, proximity, how your language, how everything contributes to de-escalating or escalating not only the resident, but you. Depersonalization. Taking care of staff. One of the biggest factors that I tell direct care staff is you have to take care of you first. This is also with people that have children or dealing with challenging people in their own lives. If you do not take care of yourself, you are not going to be able to therapeutically react to these situations. If you're dealing with a lot of issues on your own, you're angry, you're upset, you really need to check, are you going to be the best person that's going to deal with Miss Jones the 5th time tonight? Are you going to do things correctly? We have done many investigations at the Department of Health where we have had a fantastic CNA done a great job for a very long period of her career. And because of whatever was going on at home or the day, or working 12-hour shifts and really trying to help the facility and residents, absolutely makes a mistake, is aggressive physically, has made threatening comments, or done something absolutely above and beyond the decorum that's required to deal with individuals. And that's really unfortunate because it leads to an investigation and can potentially lead to a career-ending part of what they've loved to do and what they've been successful in doing. So it's really important to understand yourself, depersonalize it. It's hard not to take acting out personally. Those of you guys that have children or family members, it's even more difficult when they're your own. So we have to really realize that within ourselves, and those are very normal things. One of the things that frequently happens is power struggles. We're the adults. I'm your CNA, I'm your DON, I'm whoever it is, and I'm in control. That is absolutely an illusion. These are these people's homes. The only thing you can control really, and that's really if you know yourself, is yourself. But if Miss Jones is angry and upset, she can be angry, upset. The thing you can control is the best way to handle it might not be handling it there. It might be backing off and having somebody else that has a better relationship with her, or just backing off because you know you're not in the place because it's been the 5th time you've answered that call bell. And if you answer it one more time, you might make an inappropriate decision. So it's really important to set aside your agenda. Think about that shift. What's going on? What's going on with you? Where are you at? And one of the most powerful skills in de-escalation is listening. It's really difficult to get upset with somebody that listens to you. And try it. Have somebody scream and yell at you and just go, I really hear you. I understand. You're very upset. Reflecting words of what they're trying to say, but not just reflecting the words, connecting them to emotions. Many, many times people cannot connect words to the emotions. I've had people sit and yell and say, I am really sad right now. I am so sad that I have to be here. My family doesn't come and visit me. I'm really sad. Well, what you're telling me is you're telling me you're sad, but you sound very angry. That's very validating for an individual. It's hard to get upset with somebody that really kind of is connecting what's going on with them and putting it in words that hopefully they'll hear. And obviously, when somebody is at that highest level of escalation, we don't want to deal with them at that point. We want to give them time and space. After incidents, an absolutely paramount thing when we talk about crisis, and so frequently this is missed. We have a crisis, even if it happens well. We go in, Mrs. Jones has yelled for the 5th time, and what we've done has worked. It's been a fantastic intervention. Wow, she complied, she's happy, and we walk away and we don't do anything with that information. It just goes away, where that could be an enormous benefit for the facility, for the next staff involved, and then also the negative outcomes that come so that we don't make those mistakes again. Anytime after a crisis is done, make sure that the situation is safe and all are safe. A frequent thing, and if you've been yelled at or thrown something at, there's so many different ways of acting out. You have to look at what the reaction is going to be with staff. And frequently staff will say, oh, I'm fine, it's not that big of a deal. And often it will be a big deal. It wears on you, it affects you, especially when you've been taking care of somebody for a long period of time. You feel unappreciated. And sometimes that behavior can have nothing to do with you. It can be as a result of when this person was 20, you remind them of that person that took advantage of them or hurt them in some way. So understanding history is important, understanding our role in that. Access and providing supportive services within the facility. You got to talk to people. I will tell you that's the importance of supervision. It's mandatory in some disciplines. Medical field, clinical field, you're meeting with somebody, you're talking about residents. This is also a great system that you can put in place in facilities. Do you guys meet as a group? Let's talk about our unit. Let's talk about the environment, what's going on, what's happening with Mrs. Jones. Frequently facilities will do huddles or they'll do shift change stuff. Well, some of the things can be check-ins. How's everybody feeling tonight? Did everybody get enough rest? Let me tell you what's going on in the unit. Mrs. Jones has had a tough day shift. We've got a new staff today. Who's going to introduce her to Miss Jones? Miss Jones can be like a domino and affect the rest of the residents and our staff. So we need to know and be aware of what's happening. There are many ways of looking and analyzing behavior, and you should be creative with this, and this does not necessarily have to be time-consuming. Once you mention the word root cause analysis, you start thinking of joint commission requirements and extensive things that require drilling through everything. Well, it could be simple things like who, what, where, when, why. Why did it happen then? When did it happen? Where did it happen? In what part of the unit? What happened? And who was involved with it? And that's a really great starting point for when you look and analyze of what's going on. And you kind of take a step back. It's these seem like simple things when we talk about it, but keep in mind when you're in crisis and you're trying to 10 to 12 residents in your hallway, it's easy to forget these things. And this is why it's so important that we engage in upfront training, continuing education. We continue to talk about this and promote an environment of looking and analyzing at post-crisis situations. The debriefing, and I talked a little bit about this. There are entire models that you can train staff on debriefings. I've done debriefings with individual staff that were in pretty substantial crisis situations, large groups that had been involved where death had occurred. It is so important that you do and bring on board somebody that is able to debrief situations. No matter how big and no matter how small, there should be somebody to talk to at the end of that crisis. And it doesn't have to be immediate, but it does have to be at some point. If that shift was challenging, you schedule a meeting with the staff. Hey, you know what, before your shift comes in, I want to talk to you about your last shift 15 minutes before. Make sure you're okay. Make sure I understand what happened. Let's talk about it. With residents, when you can, post-crisis, going back and debriefing with them. Ms. Jones, I'm so sorry you were upset with me. What can we do? And this is where you can solicit their help. What can we do so that you're not so upset? What do you need from me? How can we take care of you? And there are actual structured debriefings that you can do that helps you ask the questions you want in the simplest way and helps you work with that resident so that they learn new ways of dealing with what's going on with them. Evaluating care practices, documenting, updating care plans. And I know I've heard every version of, well, care plans are just something that the state wants. Care plans are good when they work and when you use them for staff. I have been in a couple facilities that have used first-person care plans. And it's really kind of amazing to walk through a facility and talk to everyone from the front receptionist to maintenance to CNAs and go, be careful, Mrs. Jones only likes to be touched and shooken by hand. Do not pat her on the back. Do not come around her. She also likes to be wheeled out after lunch outside to sit and look at her birds. These are all things that you learn and know about the resident, and they should all be translated into your care plan. I, as a new staff, should be able to come into that care plan and be able to know some very simple things that can help me be successful with every resident in that unit. And that's really what we're looking for, a functional plan. Not a plan to appease the state, a plan to appease and make staff feel supported, that they understand what those residents need. Make sure all staff understand the care plans. It's amazing when everybody from every level of the staff understand what's going on with each one of those residents, unique to each one. And training, which we've talked about, is crucial. Training works when it comes to this, and the more you do it, the more it becomes part of one of the tools you put in your tool chest to be able to deal with individuals that might be having issues. The last thing I want to kind of tell you guys about, you guys all know that we have CMP money, a lot of CMP money. There are many models out there for crisis. I have always been a fan of the different models of where you can send somebody away in your facility, train them as a master trainer, have them come back and train all your direct care staff with competencies built into a lot of these programs. There's the Therapeutic Crisis Program in Cornell University. You send somebody to their program, they train you, you buy their handbooks, you come back and you implement an entire crisis plan in your facility. CPI, Crisis Prevention Intervention, is another model that works. And there are many other models that you can do. At this point, CMS is not required a crisis program or protocol. So there are CMP funds to help support if facilities want to take it upon themselves to start the process of crisis training. That being said, there will be new requirements, as you guys all know, in the state operations manual around trauma-informed care. There are amazing trauma-informed care programs. These are important training opportunities for people to understand trauma, the effects of trauma, how we accurately and effectively deal with trauma as caregivers. And if you're walking in a facility and working in a facility, you're a caregiver. Behavioral health requirements, assessment from walking into the facility to the course of their entire life in the facility. There will be behavioral health requirements, including therapy, assessment, psychiatry, all those things. How does admissions administration support looking at individuals and their behavior plans? Is going to be an important part in an area that we will be future focusing on surveying. And training requirements. There are very specific training requirements moving along. As some of the new regulations come out, you'll see those. All these things, if you add these elements together, you will hopefully have the ability to implement a successful crisis program, retain your staff, create a great work environment to keep people in the job, because these are important jobs. And most important, the reason why people get into this field is to take care of individuals. All the New Mexicans in New Mexico deserve all the resources we can put and support in taking care of these elderly people that are important to New Mexico. So if you have any questions, I'll turn this over to Shannon, who will go with the chat. If you have any follow-up information, my information is readily available. I can answer things individually, and I can definitely point you in directions and experts that deal with these kinds of things. But the New Mexico Department of Health is incredibly supportive of the work you do. The 76 nursing homes that support the people of New Mexico are crucial care facilities in New Mexico, and we want them all to be successful. And this is just one element that can help them be successful.
So hi, everyone. I'm going to jump in here for a moment. And what I had just put into chat is if you could indicate if a training like what Chris had done for us today on crisis prevention would be helpful, and to let us know as well if you could, what kind of things are you seeing in your building? So we have in the chat box things like verbal aggression, physical altercations, resident-to-resident aggression, resident-to-staff aggression. Of course, there's the all of the above answer. So let us know, just take a moment and enter into chat, what are you seeing and what could you use some assistance with? So I see from Jessie, she says all of the above. Anyone else have any comments that you'd like to weigh in on? What do you see in your building where we might be able to support you either with training or resources? Does anyone else want to weigh in?
And I love it, Jessie. I wholeheartedly agree with you. You're seeing all of the above, and that's why it's so important that we support. Just even the idea of dealing with an 8-10 hour shift back to back and dealing with these kinds of behaviors can be so challenging. So we need to provide some interventions, some unique thinking around these things to where we can support individuals. If you're experiencing that means mostly everybody is experiencing that in their facilities.
So Chris, if you could advance the slide to another quick chat question. Whoop, there you go. Oh, Vicki, thank you. Vicki from Bloomfield shares with us that she's also seeing all of the above as well as delirium and falls. So that's a common occurrence. We actually just had a delirium and fall webinar that I will be glad to share the posting of for you. Resident-to-resident altercations and falls. From Marissa, thanks for sharing. Can you share with us right now very quickly, if you can think of what skills do you and your staff still need to build? Is there need for crisis prevention education? Oh, okay. Jessie's sharing in chat that she has a resident who uses her call light to talk to the president. And that when they go into the room to check her because the light's on, she throws things at staff.
Yeah. Fantastic. And this is why you got to sit down with a bunch of individuals that know her and you think creatively. Off the top of my head, we have to analyze, why is she doing that? What needs are she trying to express to you about doing that? And how can we curtail that to where it's so labor intensive on staff and make it into a positive type of behavior? To where she can get her needs met. She needs to talk to the president. How can we make that happen? Obviously, within a way that is respectful to her. And I'm not talking about the actual president of the United States necessarily, although it could be her getting a tape recorder and recording a message to the president, making sure that we mail it to the president. There are so many creative things that you can do around this. But this mechanism, why does she have the need? Is she looking for attention? How can we divert her attention into something else different? If this is a resident that is able to sit down and talk, what can you negotiate with her? Miss Jones, you hit the call light. What do you need? Can we schedule time with you where we visit with you and it's focused with you, where you meet her needs that way? Or if she's able to express what she needs, I like using contracts or agreements. Miss Jones, if we do this for you, you won't hit your call light 15 times a day. So these are all unique ways. It's difficult to answer because you'd have to look at her psychological profile, her history, talk to her family. You build plans around the needs of what they're trying to express. But that's an excellent example of somebody that's trying to tell you something. And we need to figure out what that is. And I might not necessarily be the person that is, but you might talk to a family mother, a brother, a cousin that might say, oh, she had this tie to the president. She always wanted to be political. You know what really works with her with that? Get her a book and a journal, and she'll write in that, and she'll use that as an outlet for it. So frequently find the simplest thing works on the most complex problem that we ever thought, and usually unsurmountable problems. We're never going to change that behavior with her. And then some staff member on the third shift one day found a way, and we find out that, oh, well, I know why she does that. You just have to give her this, and then you've got it. So you have to be creative and use the people around you. Most likely somebody has something that worked with her, or involve the resident in part of their plan. And that is a mandatory part. If you've got folks that are cognitively able to work on a plan with you, you should involve them. You're more apt to follow a plan that you come up with. Frequently, I will ask residents and say, well, what do I got to do? And I call the car salesman talk. What do I got to get you to do to have good behavior at dinner time? What do I got to get you to do to take a bath today? And they'll answer you, well, I don't want to take a bath today. Okay, when do you want to take a bath? I like to take it on Thursday at 7. Let's see if we can schedule that around. Think of what you do if they follow that and you go back and go back to that 7th day that they agreed. It's the easiest thing to say. Well, this is what you wanted. And that's a very powerful thing, to have people feel that they're in control. And we want them to have that control. The more control you have, the more you have the feeling over your own life and taking charge. It's got to be hard having a lot of your care needs met by other people. So I would look at it that way. And that's a fun one to kind of go to your team and ask, what can we do? What are we going to do to fix this problem? You're not alone.
Yes. And Jesse did share the creative way that they solved that is to keep the door slightly open so they can make sure she's okay, doesn't need anything in particular, so she can continue her conversation undisturbed. And you also bring up a good point, Jesse, which is that you've shared this among staff so they don't get hurt. So once somebody comes up with a creative solution, share the knowledge, share the wealth, if you will, so everybody can be successful.
And I love that. That's such a simple intervention. And who would have thought of that? Sometimes we make things more complex than they are. A simple thing of opening the door and allowing her to be able to do what she needs to do. It's fantastic.
That's very good. So Chris, could you advance one more so we can show the training videos? We wanted to make you aware that there are some training resources out there. The Crisis Prevention Institute does have small webinars of about a half hour in length on a number of different topics, and we encourage you to take a look at these. And then also, Chris shared his email so that if you're interested in potentially doing some crisis prevention training within your own facility or within your corporation, please apply for the civil monetary penalty funds that exist to be able to potentially put a good program in place. And Chris is very happy to help you with information on how to get that going. Since I don't see any questions, we want to get you guys back to your day. I want to say thank you very much to our speaker, Chris Burmeister, and thank you on behalf of the New Mexico Department of Health, the New Mexico Healthcare Association, and Health Insight for attending today's half-hour Hot Topics. So thank you very much, and we appreciate your time today. Have a great weekend.